Hello, I'd like to thank HSR UK 2020 for inviting this presentation of the work of the Pre-Hospital ECG2 study team. Co-authors are listed here from Kingston University and St George's University of London, from Swansea University, the University of Leeds, and our patient and public representatives. I'm going to talk to you today about a qualitative study of emergency medical services clinicians' decisions when to perform a pre-hospital 12-lead ECG in patients with acute coronary syndrome. This study forms part of an ongoing mixed method study of the use and impact of the pre-hospital 12-lead ECG in the primary PCI era, funded by the British Heart Foundation. Use of the pre-hospital 12-lead ECG is recommended in international guidance for the early assessment of patients presenting with suspected acute coronary syndrome to emergency medical services. The pre-hospital 12-lead ECG supports decision-making in three components of care: targeted pre-hospital treatment, transport to the appropriate receiving hospital, and provision of information required to activate a receiving cardiac catheter laboratory should particular types of myocardial infarction be recognised. Association of the pre-hospital ECG has been found with process improvements such as speed to the desired treatment outcome, as well as short-term mortality benefit. However, the pre-hospital ECG has been found to be underutilised, particularly in older patients, women and people with comorbidity. Staff, gender and uncontrolled confounding of presenting symptoms have been put forward as potential explanations for the variation in practice and deviation from international guidelines. Against this background, we are conducting our study. The pre-hospital 12-lead ECG study is being undertaken in several components. The protocol has been published with the reference here. In brief, we're conducting a population-based linked cohort study using the National Myocardial Infarction Audit Programme from 2010 to 2017, conducting a retrospective chart review of emergency medical services clinical records, as well as the part that we've completed and presenting here, emergency medical service clinicians self-report on their pre-hospital ECG recording. We conducted a qualitative phenomenological study using 6 focus groups with a semi-structured topic guide in 3 UK regions. We selected a purposive sample from within volunteer emergency medical service clinicians recruited by 3 ambulance service NHS trusts. Where we were oversubscribed, we stratified by length of experience as a clinician and by study site within the 3 regions. We recorded, transcribed and anonymised each focus group, familiarised ourselves with the data, formed and iterated and reiterated a coding framework and constructed themes with the study team, including our patient and public representatives, who extensively discussed the transcripts. Of the 47 clinicians who participated, there was a wide span of clinical experience, ranging from 9 months to 31 years. The majority of our participants were paramedics, although we had invited other grades of EMS clinician. Focus groups and their participants were not always in agreement, and as researchers we experienced a sense of regional difference in content and context. However, there was one clear message expressed by all participants, this being a desire to perform a pre-hospital 12-lead ECG with all patients they suspected as having acute coronary syndromes. However, they described a setting characterised by uncertainty and messy context, in which spotting the suspected acute coronary syndrome patient was not always straightforward, and hence then neither was the decision to perform or not perform a 12-lead ECG. From the data, we drew out 3 themes of influence on the decision to perform an ECG, which I'll go through in turn with illustrative verbatim quotes. Our first theme we've termed surface characteristics. Discussion in each of the focus groups initially focused on typical presentations of acute coronary syndrome. These cases would be referred to as barn door events and would lead clinicians to definitely carrying out a 12-lead ECG. In these cases, they reported little delay. Most of the clinicians considered themselves to be clear on these typical symptoms, and would like to confirm the diagnosis as quickly as possible. We see this in the first quote in the green box, although we note that there appears to be some reliance on intuition as well. Our participants also discussed the impacts of the patient's visible characteristics, age, sex, ethnicity, and so on. While our participants were quite varied in their views on the level of influence of these factors, their interaction with privacy was more readily agreed on, particularly when recalling that emergency medical services operate either in public places or in people's homes at times without chaperone. The decision to carry out a 12-lead examination was not always then one which was unambiguous. Once the surface characteristics had been discussed, it became apparent that there were many other factors which also played a role in the decision making. Our second theme relates to another group of underlying factors that clinicians talked about in relation to 12-lead ECG. There was initial discussion about the difference between paramedics who had been trained under different programs and on what was described as locally varied ongoing training and education, and the role of that linked very much to confidence of clinicians in carrying out the 12-lead ECG. There was wide variation in confidence reporting, although interestingly this was usually described as other clinicians, not the participants themselves. Perhaps this was as many of the focus group participants were self-selecting and likely included clinicians who were inherently more interested in the 12-lead ECG. What was clear, however, was the power of cases where the clinician had not initially suspected acute coronary syndrome. Their recognition of the barn door cases earlier, the patterns just weren't there. The impact that such experiences had had on individuals' subsequent decision making, usually recorded as becoming more cautious. Our third theme deals with factors that may be external to clinicians and relate to pressures within the broader healthcare system they operate in. While two of the sub-themes appeared entirely practical, that is, where equipment was available or not, and the physical distance to an intervention centre as opposed to the nearest emergency department, these decisions appeared to be closely related to policy. In all of the focus groups, there was some confusion about differing local guidance and the role of local guidance versus being a registered health professional with autonomy to decide when an ECG should be carried out. These policies were described as manifesting themselves with many clinicians carrying out more ECGs than they may have strictly decided to autonomously. These decisions were made further complex by operational pressures. These could relate to time or resources and appear to have different levels of impact on individual clinicians on whether they decided to carry out a 12-lead ECG or not. There were those who felt pressured to hurry, and there were those who felt clear that their experience with the patient dictated the time spent. Most of them talked about trying to balance the need to work quickly and efficiently while also considering the welfare of the patient. Here we present these multiple influences pictorially, with the clinician really very much in the middle of them. Importantly for us, from the data we considered these influences appeared to be in competition, at least at times. While the stories told gave examples of how these competing influences were overcome in practice with the individual patient, the overall picture was not one of consistency or clarity. These competing areas of influence on decisions at the patient, clinician and system level appear to be underpinned by these concepts of autonomy that I've just mentioned. Patient autonomy was described as in terms of patient refusal. Our participants rarely reported patients refusing to allow a 12-lead ECG to be carried out. However, there was some evidence that this does occasionally happen, as illustrated in the quote here. Clinicians were clear that they could not carry out an ECG against the patient's wishes, nor that take them to the emergency department. However, in most instances, it appeared that patients were conveyed unexamined if it was deemed to be in their best interest. The influences will also appear to be interwoven with the concept of clinician autonomy, with some of the influences on decisions about 12-lead ECG either limiting them or enabling them to operate. This point in the focus groups always sparked lively debate on the relationship of such autonomy with the enactment of system-led policies for practice. As our participants did not present an answer to this, we don't either, but speculate on what our findings might suggest. So in conclusion, the factors described as influencing clinicians' decisions on whether to carry out 12-lead ECG in acute coronary syndromes range from straightforward to complex and difficult to unpick. Qualitatively, our clinicians reported performing 12-lead prehospital ECGs wherever possible, but also reported these multifaceted influences. The quantitative arm of this study, due to report in October, will enable us to examine this nationally alongside any association with patient outcomes. However, from the qualitative study alone, we suggest the implication of study for practice are twofold. First, a practical need to reinforce the content of guidelines in a standardised manner, and to do so in real-world scenarios in which individual interpretations of the situation might be explored. And secondly, to give broader consideration to how clinical autonomy can be supported while also maintaining core guideline-led practice where it is based on evidence for improved outcomes for patients. Thank you for listening. We welcome further discussion and questions. Please do contact us.